introduce Sarah Stranberg, who is another Minnesotan, or at least has Minnesota contact, and because she and I worked together for many, many years at the University of Minnesota, and it was wonderful that she was able to join us at Stanford. So she's now a member of our team at Stanford and has boatloads of experience in working with speech and swallowing challenges in people with neuromuscular disorders, and specifically myotonic dystrophy, because we worked together a lot in Minnesota before Stanford. So it's great to have Sarah here, and without further ado, Sarah Stranberg. Thank you.
Thank you. Thank you. Thank you. I appreciate the opportunity to be here to be able to talk about swallowing issues. I think it was a topic that somebody had requested from last year's meeting. So just to get started, swallowing, we often are thinking about what we're going to eat and what we've eaten, but we rarely think about how we eat, the mechanics of it, until something starts to be problematic. And so we're constantly taking in foods and liquids, and this is kind of a view of our head and neck from the side if we were cut in half. And I'll have it on a couple of my slides just so you can appreciate the complexity of the anatomy of our upper aero and digestive tracts. So as we're thinking about what great food we're going to have next, it becomes a much more complicated process once we try eating the food. And the green arrows show the pathway that we want our food and liquids to go. So we need to take them into our mouth, chew them, and then pass them down the throat into the esophagus, which I've got marked with the green arrow. As you can see from the anatomy, at one point there, one pipe becomes two pipes. And in addition to the esophagus, we have our airway. And the red arrows would indicate material or the direction of airflow, and swallowing difficulties can lead to food and liquids going down the wrong way. So again, just understanding the complexity of the anatomy, we want things to go in the mouth, end up in the stomach, and not in our lungs, but you can see the proximity of our esophagus and our airway. And this is another drawing that shows up in many of the educational booklets of just how complex it is when we chew and swallow. So we need to take things into our mouth. We have to close our lips tightly. Chewing is a lot more than just the teeth. So it's the jaw strength to chew our food. And then our tongue has to be coordinated and strong enough to move it back in the mouth in order for our body to trigger a swallow. So looks like most people have food or liquid in front of them. So take the next couple swallows mindfully and pay attention and actually put your hand up to your throat and feel what is happening. So as we swallow, and the food and liquid, which is the yellow on the screen, as it moves back, a lot of anatomical kind of changes happen in the position of everything in our throat in order to protect the airway, to protect the trachea, and hopefully guide everything towards the esophagus. Okay, and so I see people checking their swallows, and it gives you an appreciation for what's going on. So dysphagia is a word not everyone's familiar with, but I'm sure all of you have seen in the literature and have discussed in the past. But dysphagia is a disorder of swallowing, and there's literally thousands of different ways and reasons that our swallowing can become impaired. Neuromuscular diseases being just a small percentage of those. And our swallowing can kind of go wrong from any perspective. It can be that it's difficult to manage things in our mouth, control the food and liquid in our mouth. It can be an issue in our throat, or it can be an issue in our esophagus, which is connecting our throat and to our stomach. And that word pharyngeal that's up there, that's the medical term for basically for the throat. And you'll see that frequently. So despite the fact that so many people with neuromuscular disorders, including the myotonic dystrophies, have dysphagia, This is one of the main books in our GI radiology at Stanford in the back room where the doctors have their references. I took this photo just the other day, and the book is several inches thick, and this is supposed to be all-encompassing of GI radiology issues. And on the right, I have a snapshot of the only material in the book on neuromuscular and GI issues. So just a paragraph for many of the conditions. And I think this just indicates that it's not a topic that's well understood by many professionals, even medical professionals practicing in the areas related to GI. So I thought that that was interesting. While there is some research, we definitely need to contribute more to that database. So as many of you know, there's GI issues are rather common in the myotonic dystrophies, and actually reports are about a third of the individuals will have GI complaints before they are aware of their diagnosis. And by GI issues, we talk about the whole range. So swallowing can be just one. Issues with reflux, I think some of the other GI issues were mentioned earlier with the constipation, diarrhea, irritable bowel syndrome type issues, and also with the gallbladder. So the swallowing is just one aspect that may impact one's ability to eat. But what happens specifically in myotonic dystrophy? And I should point out that dysphagia is much more common, much more prevalent, and more severe in myotonic dystrophy type 1 as opposed to type 2. But these general principles apply to both types. And it starts with the facial weakness, the jaw weakness affects our chewing. So chewing, again, is so much more than just the teeth. So the facial weakness has impact on our ability to chew. And we might be able to chew, but it might just take a much longer period of time, take a lot more effort. Then tongue weakness or poor coordination of the tongue can affect how our tongue moves the food around in our mouth and moves it back towards our throat. The palate, which is the thing that's hanging down in the back of our mouth when we look in there, that rises to seal off our nasal cavity when we swallow, and that can be weakened so that many people will experience food or liquid going up into the nasal cavity. The swallow then starts, but it's usually a little bit slow, kind of sluggish, and there's reduced pharyngeal peristalsis, and that's a fancy way of talking about how the throat works. So peristalsis is the contraction and relaxation of the throat, kind of in a wave-like pattern as it pushes the food down. And this weakness can then result in food, usually the more solid food, kind of getting stuck in the throat. So people will have frequently complain of stuff still feels like it's stuck in there after I've swallowed. There can be difficulty passing food down and into the esophagus and actually down the esophagus. And people will have complaints of food either sticking high up or even farther down in the chest. And then the main difficulty that we want to prevent is aspiration. And aspiration is when food or liquid doesn't get to the esophagus, but it gets towards the airway. And usually that's just part of the sip or the bite, but we don't want any food or liquid going down towards our lungs because of the health consequences. So what are some of the possible signs of dysphagia? I've listed, and this looks like a long list, so all of these things don't happen in every situation, but these are just some of the things that you might be noticing or might want to be careful in monitoring for. It can start with just the inability or difficulty getting food or liquid into the mouth. Some might get in there and some might spill out, and so again, the facial weakness can affect our ability to take things into the mouth, difficulty moving food around, food in liquid either draining out of the mouth or going into the nose. And then obviously choking, and that's usually a much more dramatic manifestation of the dysphagia. More often than not, it's much more subtle, either coughing or a lot of throat clearing. So a lot of taking that throat clear after you swallow. And that may be the sign that your body is trying to protect the airway, or something's trying to go down the wrong way. Signs of reflux, gastric reflux or heartburn can be present. And then a wonderful paper in one of the journals in just this past December indicated that difficulty swallowing pills is a major barrier to many people with myotonic dystrophy being adherent to their medications. So some people will just have difficulty swallowing pills. But there's lots of other possible signs, and some of these, again, if you have or notice something on this list, it doesn't mean you've got dysphagia, but repeat pneumonias. So if food or liquid is going down the wrong way, and bacteria can create a pneumonia or just that chronic upper respiratory infection. The change in the amount of food or liquid you're drinking, which may or may not lead to weight loss. It could be that just it takes a lot longer to eat, and you realize that everyone else is finished and you haven't gotten very far through your meal. Food avoidance, so many times our body knows before we are even cognizant of it that something isn't quite right. So we might start avoiding foods and not even really be able to put our finger on the fact that they're harder for us to eat. And then exhaustion due to eating. When eating becomes, people will describe it as it becomes work. It's not enjoyable anymore. So those are all possible signs that something is perhaps impaired. But again, that list of GI symptoms that I put up, also many of those could account for some of these: weight loss, avoiding certain foods. So sometimes it takes a while to kind of tease out what is going on, and that's why it's just important dialogue to have with your physician. What are the risks? The risks can be things like aspiration, which lead to pneumonias, and in combination with the respiratory compromise in myotonic dystrophy, pneumonia can be quite a serious issue, can be a life-ending issue. Surprisingly, despite the estimate is about 60% of people with myotonic dystrophy type 1 having dysphagia, the percentage of those that actually aspirate is much, much smaller. It definitely happens and is a risk that we have to avoid, but it's really thought that the body has done a great deal to compromise for the changes in the system. So many of your bodies have already kind of adapted to some of the changes in order to prevent aspiration from occurring. Much more rare, but again, airway obstruction, or actually having a piece of food blocking the windpipe where you can't exchange air. It can happen that people would need like the Heimlich maneuver or some assistance. Then just compromised nutrition, hydration. So just having difficulty with maintaining a weight and also just maintaining proper hydration can be quite difficult. And then, as I said, reduced adherence to medications is recently been documented as quite high because of swallowing. So what do we do, or what do you do if you should notice changes? I think first bringing it to your doctor's attention, and your doctor will usually set you up for a swallowing evaluation. Most of the clinics have somebody assisting with that if you're at a multidisciplinary clinic. Physicians, I'm a speech language pathologist, and we deal with swallowing. In many centers, actually also particularly in California, an occupational therapist might be the one discussing swallowing. But I think the first and most important step is just the interview or the discussion that I have with people about the changes that they're noticing. And there's just certain words and the way some of these problems are described that are very telling. And so I think that's a really important step. And I actually put I know it's a little bit hard to read from the back, but this is a questionnaire that's used widely, that's been published. And you can see how the questions are somewhat broad, but this simple 10 questionnaire has proven to really also identify when people have dysphagia. Can I go backwards? The first step then after the interview is have an examination of your oral motor or your oral facial movement, the strength, the coordination of the face, the lips, the tongue. And then there would be a swallowing or a dysphagia evaluation. And some of those are just done clinically, where a therapist usually would observe you taking something to eat or drink. And then based on that, you may be referred for a more formal swallow study. And I've got examples of these two. So these are the different formats for actually visualizing what's happening in the throat. On the left, I have just a still shot of a modified barium swallow study, or a video fluoroscopic swallow study. And in real life, this would be a movie, actually, of that skeleton there swallowing. And they're very quick tests that are done in a radiology suite, usually with a radiologist and a speech pathologist. But you're just given a few bites and sips of food and liquid that have a little bit of barium, white barium, mixed in. And as you swallow, you can see that the barium shows up black on the imaging, and we can tell exactly where things are getting stuck. We can see what parts of the throat might be difficult, and we can actually see the aspiration, because part of managing the problem is really understanding what exactly is happening. The picture on the right would also be a movie type image in real life. This is just a still shot, and this is actually a still shot of my swallowing, a picture that I took of myself about 20 years ago. But this is where a fiber optic camera is placed in the nose, and you're actually looking down, and that's my throat. Those the white strips are my vocal cords. When they're open, you can see my airway. And that small little image there in the corner is a picture of being given some applesauce that's got a little bit of blue dye in it, and the swallow can be watched from that perspective. Are things sticking in the throat? Are they going down the wrong way? And so these are usually completed by an ear, nose, and throat otolaryngologist with a speech pathologist. And so there's different reasons to pick one or the other, or some people might end up having both. What do we do about swallowing issues? One of the first steps would be really looking at the diet, seeing if there's just certain foods that can be replaced with something else. I know changing what we eat is never easy, so none of us want to be restricted or told we can't have something. But again, it's about weighing risks and benefits, and changing the texture of the food or changing the texture of the liquid. It's not actually very common that individuals with myotonic dystrophy will have to change the liquids that they drink, but occasionally that's needed, and that's done by there's different products that can be added to your liquid to make them a little bit thicker, and the thickness actually helps guide them down the right way. It helps our body sense them better, and usually improves swallowing if it's indicated. It's not a Band-Aid, so actually it can make things worse in some individuals. So you want that assessment to know for sure if that's something that would really be needed. Feeding strategies, and by that, the positioning that you have when you're eating, and so positioning in a wheelchair while you're at meals, so working with the therapists that are doing your wheelchair seating, or the best positioning in a chair for meals. Adapted utensils and cups. I have some pictures of some items, and coming up here on the slides. And then at lunchtime and afterwards, there'll be some brochures that Jennifer ordered from one of the dysphagia companies that features a lot of these different products in them. And I think the booklets will be on the Stanford table out in the entryway. A lot of it comes down to how we eat, trying to slow down, take small bites. Again, very easy directions for us to say to someone. All of that is very hard to do in real life. We're usually eating and drinking in a social environment, even if that's just our dining room table. And it's hard to be mindful of changing our eating behaviors. And I just listed 3 of the tips. There are many, many more. But a lot of it has to do with slowing down, taking smaller sips, which again can be hard when we're all chasing around and eating sometimes on the go. Other medical management, so if some of the other GI issues, as it gets to be more esophageal related, our GI experts can help with recommendations. Occasionally, and it would be very rare in myotonic dystrophy, a person may not be able to sustain their nutrition with just eating by mouth. So some people do have a feeding tube place for some access to get some nutrition, because we need that fuel to keep the body as strong as possible. Again, that would be just a very small number of people. And I put this up here just because I know people with swallowing issues are desperate to have them resolved. But currently, looking at all the research, there's no conclusive evidence to support the benefit of doing swallowing exercises. So many people will have those prescribed by a well-meaning therapist based upon the success of swallowing exercises for other neurologic conditions like stroke recovery and things like that. But again, it's a personal choice if it's something that you want to try, but right now there's no definitive research to support that, as well as electrical stimulation. So some facilities actually have systems where you're providing electrical stimulation to the outside of the neck towards the throat, and a lot of research is being done right now on this. It's proving beneficial with some populations, non-neurologic populations, but that's something where we still need more evidence to know for sure. And on this busy slide, I just put some pictures of some adaptive utensils and cups that really can make a difference. And so the ones on the left with the kind of the cutout, those are nosy cups, and everyone gets it and is not sure what angle they're supposed to drink it. But so I have got the picture of the woman there. So the nosy cup is actually just got the cutout for where your nose is when you're tipping the cup. And that's to prevent you from having to put your head back, because when we hyperextend our neck back to drink out of a water bottle per se, that's when our airway is most vulnerable and open during the swallowing. So the nosy cups are great. The cups usually are, sippy cup is the word that's in most of the catalogs for the ones on the right. The one with the blue background with the little knob on the top is a really fancy swallowing cup that is marketed towards people with swallowing difficulties. And again, the prices just become so high, whereas the little blue ones almost do the same thing, and you can get them a multi-pack of them at Target for just a fraction of the cost. And to be honest, when you're trying to slow down how much fluid you're taking with each sip, just a regular old coffee cup with the lid, just like we've got in the back of the room there, the coffee cup that's there, it really does wonders. And then I've got just some of the adaptive spoons, because when we work hard to get food and liquid to our mouth, a lot of times we want it, especially if it's effortful, we want to make each attempt worth it, so to speak, so we can really have those spoons loaded with a lot of food, which can really exacerbate the difficulty. So sometimes just the simple trick is just changing the size of the spoon, making that smaller. You can't get quite as much. So just little things that can really improve swallowing safety and also enjoyment. I put some resources up here. Talk to your doctor. Oops, I have a typo there. The MD clinics with multiple team members, speech, OTs, registered dietitians. MDA has some wonderful resources. The Myotonic Dystrophy Foundation, they have the best seminar. I want to say it's like 45, 50 minutes long by one of our nation's swallowing experts, does a wonderful talk that's on there. The NIH at these specific websites. NINCD is a branch of the NIH that looks at, that this would fall under, and then ASHA is the speech pathology kind of home organization, and all of those, if those specific sites have wonderful resources about what I have talked about here today. So I really appreciate the opportunity to speak at a conference like this. So if you have questions, please write them down or come up to me during one of the breaks to share your experiences. Thank you.